Thank you. Thank you for inviting me today and allow me to talk. I'm Keisuke Ejima, Assistant Professor at School of Medicine, Nanyang Technological University, Singapore. I'm pretty much inspired by every talk today, this week, and had great conversation with many of the participants already. So I'll talk about the viral load. Viral load is amount of virus in sample. In general, viral load is measured by PCR test. The test are performed to identify patient. So, for example, people seeking for treatment, or people involved in a contact tracing, or people are involved in screening event. Those people are tested using PCR. And the test could be performed multiple times for the same person to monitor disease progression. So during the pandemic, PCR tests become commonly available everywhere during the pandemic. And massive viral load data have become available. So I think since then, more scientists started using the viral load data for beyond diagnosis or monitoring disease progression, such as the epidemiology and public health purposes. So, however, there are two issues when we use viral load data. The first issue is that the viral load dynamically changes over the course of infection. What I mean is the viral load initially exponentially increases and then hit a peak and declines after that. And so the standardization of viral load data concerning time is needed. So, for example, here, it is not fair to compare the viral load at the peak and the viral load at the late phase of infection. And second issue is that the available data is sparse like this. In general, PCR tests are conducted only once for diagnosis or screening purpose. When hospitalized patients are monitored, PCR tests are repeated multiple times. But there is still some time interval between the test, like 2 or 3 days. So to solve these two issues, mathematical model to describe the viral load dynamics have been proposed to fully understand the temporal change in viral load. So this is the outline of this my talk today. First, I introduced several viral dynamics models. Here we specifically focus on the models for viruses causing acute infection, such as influenza and of course COVID. So of course there are viral dynamics models for viruses causing chronic infections, for example HIV. Those are not in the scope of this talk. And then I introduced some example application of the viral dynamics model for epidemiology. So let me introduce some of the viral dynamics model. This is the simplest model, which is called target cell limited model. This model is composed of 3 compartments, PIV, so uninfected cell, infected cell, and viruses. Uninfected cells turn into the infected cells once they infected. And the infection rate is determined by the number of viruses. So the infection rate is beta V. And the infected cells produce viruses, but they die with the constant rate delta. And viruses population V, viruses are also washed out over time by the rate of C. So in this model, viral load reduction occurs due to the depletion of infected cells or targeted cells, like normal SIR model. So the model is called a target cell limited model. So as you can think, the target cell model is too simple. So the more complex model has been proposed. And this is another simple example, but this model is concerning the eclipse phase. This is a quite easy extension because we just need to add one more compartment before the infected cell compartment. And of course, the model can be extended to explicitly incorporate the immunological response, such as humoral immunity component, cell-mediated immunity component, and inflammatory cytokines. This is possible, and this is quite complex. I'm not explaining everything, but the possibility is we can incorporate the immunological response over time. And once the model is specified and viral load or other relevant data are collected, such as immunological response, we can quantify the model. When the data is kind of cross-sectional type data, which I mean is one data point is available from each patient, then we can just use simple least square method or maximal likelihood estimation approach. So in this case, we can just estimate population level parameters, not individual level parameters. And when the data is the longitudinal, which I mean is multiple data points are available from each patient, then we can again use least square model, least square approach or maximal likelihood approach for each individual. Or we can use what is called non-linear mixed effect model. With longitudinal data, we can estimate both population level parameter as well as the individual level parameter. And when we use a non-linear mixed effect model, we can estimate parameters with limited data. So for example, this is just an example, but these dots correspond to data, and this curve corresponds to the estimated curve. Although the data is not collected before the peak for this patient, because the data analyzed with other patient data at the same time. So we can estimate the parameter for this patient, even though there is no data before the peak. So here's something we have to think about when we build models and fit the model to the data. First, I introduced a few potential models, simpler model to complex model. The simplest model is, as I said, the target cell limited model. We can also incorporate complex immunological response, which is biologically more reasonable. However, we have to think the complex model have many parameters. So when we fit the model to the data, we may need data beyond the viral load, or we may have to fix some parameters. So for example, if we want to incorporate immunological response in the model, we may have to measure the immunological response over time, not just the viral load. So the model selection is dependent on the data availability. And also, from statistical standpoint, goodness of fit, such as AIC, BIC, MSE, should also be considered in the model selection. And also, we also have to specify the time scale of the model. There are three commonly used time scale. One is the time since infection. Second one is the time since symptom onset. And the third one is a time since diagnosis. So each time scale has pros and cons. So for example, the timing of infection is not observable. So if we want to use a time after infection, we have to estimate the timing of infection. But there is some assumption, like some scientists assume that the viral load at timing of infection is 10 to the negative second power. And when we use a time since the symptom onset, the timing of symptom onset is only applicable for the symptomatic cases. So we can use this same time scale for asymptomatic cases. Also, we have to be careful about the definition of symptom. So it could be a fever or like sore throat or other symptoms. So you have to, it depends on the disease, also depends on the definition of symptom. And then lastly, timing of diagnosis is the most consistent. However, also we have to think it will be influenced by epidemiological societal situation. So for example, people may go and get tested as soon as possible in 2020, at the early of the COVID pandemic. But now, maybe not all people go get tested as soon as possible. So we have to be careful when we use the time since diagnosis as a time scale. So from here, I introduce some example of an application of viral dynamics model to epidemiology. So first, let's just focus on the early phase of infection. Assuming that the viral load infection, we can estimate the timing of infection by what is called back calculate the model. So once the timing of infection is estimated and timing of symptom onset is recorded, we can compute the incubation period for each patient. So here we use a patient data collected during the early phase of the pandemic, and we fitted the target cell limited model. So it's difficult to see, but this is the data and this is a fitted curve, and this is the timing of the infection with uncertainty. So we do the same thing for all patient data, and this is the timing of infection for each patient with the 95% confidence interval. So then we can further estimate the incubation period distribution by fitting log normal distribution to the estimated data. So we did this for all patients or only the Asian data or European data. But we constantly find that the estimated median incubation period was about 5 days, which is consistent with the finding from other epidemiological studies using traditional interview-based approach. The major strengths of this approach compared with traditional interview-based approach is that this approach is not influenced by the recording bias. And this approach can be applicable to animal or livestock infectious disease, for which the recording, the timing of exposure is basically impossible. However, we have to be careful because there's a limitation, of course. The limitation of this approach is that we assume that the model structure is correct, and also the viral load data at infection is correct. I mean, the assumption is correct. Also, using a similar approach, by estimating timing of infection, we can distinguish local case and imported cases. This was quite important at the early phase of the pandemic because once many local cases are identified, the countermeasure could be shifted from containment to mitigation, and more resources should be spent for reducing disease transmission rather than screening at the border. So here are the data of initial 12 cases in Singapore in early 2020. So initially, the government concluded that all these 12 cases are imported, not the local cases. However, we analyzed these patient data because there are long-term data available, and there are 6 patients who could be a result of local transmission. So here, the red dotted line here is the arrival date to Singapore. And this blue shaded area is the estimated timing of infection. So this case, it is clearly imported because they arrived after infection. However, for example, this case, the estimated timing of infection could be occurred after the arrival. So this is suggesting that there is a possibility that this case might be local case. So we did analysis for the other 6 cases as well. So interestingly, further investigation was conducted, and they identified that among 6 suspicious local infections, there are 3 cases whose contact are also the case, which was identified before. So this is partially validating approach. Unfortunately, there's no genetic data, so we don't know whether this is the actual pair, but at least the epidemiological investigation identify these are the family member or the contact of these suspicious cases. The strength of this approach is that the computation is solely based on viral load data. And again, approach is not influenced by recall or reporting biases. However, this approach requires multiple time point viral load data from the same patient, which might be challenging. And next, let us focus on the late phase of infection. So if we focus on the late phase of infection, we can estimate when patient lose infectiousness, assuming that there is an infectiousness threshold. So that if the viral load is above this threshold, they are infectious. So for this particular patient, here is the timing that he loses infectiousness. So using this approach, we can determine the appropriate length of isolation. As you can imagine, longer isolation is good to reduce the further infection risk. However, it may impose the isolated people to be isolated even after losing infectiousness. So here we define risk and burden. Let's say this patient ends isolation at this time point. Because the viral load is above the threshold, this person is considered to be infectious. So the risk is defined as the probability of ending isolation of patients who are still infectious. And the next, this figure of viral load of this patient, for this patient, let's say this is the timing of ending isolation. Then obviously, at the timing of ending isolation, this person is not infectious. However, he has been or she has been isolated longer than necessary after losing infectiousness, because at this time point, he or she is supposed to lose infectiousness. So these lengths here, the burden is defined as length of unnecessarily prolonged isolation. So proper isolation length should consider the balance of these two metrics. So here is a computed risk and burden depending on the length of isolation. We change the isolation period from 2 to 20. So as you can see here, the longer isolation is to lower risk. However, the cost of as a cost of high burden. So we need to think about the balance between risk and burden. So let's say 1% of the risk is acceptable, which is 10. Then the 10 days isolation is recommended. However, the burden is about 6.8 days. And so far, I introduced mainly my study, but let me introduce other example using viral load data. So these two studies is using viral load distribution at certain time point, because the viral distribution at certain point is useful in assessing the epidemiological situation. As panel A shows, that when sampling is performed at growth phase, most samples are collected from those who are infected recently. Whereas when the sampling is done at declining phase, more samples are collected from those infected a while ago. So this difference is reflected in the viral load distribution. Specifically, if you look at the distribution, low median of CD value distribution and weak negative skewness of the distribution is observed in the growing phase. And whereas high median and strong negative skewness is observed at declining phase. So again, the viral load distribution is useful to assess whether the epidemic is growing or declining. And further, this approach has been extended to estimate estimate the effective reproduction number. So in this figure, the black line corresponds to the reproduction number estimated from the incidence data using the conventional approach, whereas This red line, bar plot correspond to the reproduction number estimated from CT value data, which is quite consistent with the black line. And lastly,
You wind up in a minute.
Okay. Lastly, the viral dynamics model can be used to estimate outbreak risk, assuming it is associated with infectiousness. Dr. Hart developed a simulation framework to estimate outbreak risk under different screening strategy based on simulation using viral dynamics. Although I have been focusing on viral dynamics model, of course, there are more biological data is available. So this is just an example, but recently we developed the mathematical model describe how the antibody level changes over time. And for example, the interesting finding is here. The dynamics is different between the Moderna and the Pfizer. So those who received Moderna, the antibody level is sustained at a high level for a long time. So here is some discussion. We don't have time, but yeah, more. This is still I think a new the field. So more study is needed to especially to validate the new approach, and we have to compare the traditional approach versus the viral load-based approach, and because there are pros and cons as I described earlier. And also the sample size is difficult to calculate because this is a quite complex approach. But the simulation approach might be helpful to compute the sample size. I focus on the epidemiological application, but of course the model can be applied to, for example, the drug development and also clinical medicine. So I think the viral dynamics model has a huge potential in taking a pivotal role in pandemic preparedness. And thank you very much for your attention. I'd like to take
Thanks very much. This kind of data was really, really helpful when we were looking at testing and contact tracing strategies. I was wondering, I'm having a hard time getting my head around how you can estimate the pre-symptom onset bit of your viral load curve when you only have post-symptom onset data. And you mentioned something about specifying the viral P0.
So, so I think there are two approaches when we fit the model. One, the first approach is simply fit the model to each individual. But the approach we took is what is called nonlinear mixed effect model. So mixed effect model is composed of two components, fixed effect and random effect. Fixed effect is shared by all the people. So how can I say? We can partially estimate this part using other people's estimated parameter.
But if you don't have anybody's pre-symptom viral load data,
then
you do.
We cannot because there's no information. Especially it's an issue for COVID because the peak appears soon after the symptom onset.
Oh, thank you.
Any other questions? Yeah. Go ahead.
Me first? Sorry. So I understand that you might be working on Singapore data.
Yes.
So have you tried to link the viral load data with the contact tracing data in Singapore, like to see whether people with higher viral load, he or his or her close contact will get will be more likely to get infected?
Yeah, that's a future study. I don't have access to the contact trace data. I mean, the viral data and the contact trace data supposed to be kind of linked, but at this moment, I don't have data to the access to the data or contact trace. But that would be helpful to validate this approach.
Just briefly, you talked about some of the mechanistic viral load models here, and I think many researchers, myself included, and we've heard some this week, have often used, for epidemiological purposes, empirically a triangle-shaped model where there's not formally an underlying viral dynamics mechanism. And I wonder if you could comment on that. Is that A lot of your curves look a lot like triangles. And so I guess I wonder, is the empirical triangle approach good enough?
That's a good question. I think yes, it depends on purpose. So for example, if we want to incorporate the pharmacological intervention like drug impact, I think we need to, we need this mechanistic model. So yeah, I think it depends on purpose. Like just want to fit the model and want to know the timing of infection and timing of losing infection, I think the triangle approach might be better. Yeah, I agree.
We have one more question, perhaps? Right.
I was wondering if you looked at the balance of the benefit of reducing isolation in terms of the cost of repeatedly testing people to see when they drop below the threshold.
Yeah, actually, we define the risk and burden here like this, but this is not only the definition, and I think the cost effectiveness analysis is the future study, yes.
Well, thank you very much. And reminder that we start the last day of the workshop at 10 o'clock tomorrow morning, but that's finished by thanking Keisuke.